I knew that when I got into medicine, I loved education. I loved the fact that I could get my patients involved in their own care. And dermatology totally does that.
So we have Mariana Cooper here with us tonight. Mariana is a PA. She's currently a derm PA, but she's done several different specialties. So it's going to be a fun night, and I have a lot of questions for Mariana. So thank you so much, Mariana, for coming on tonight with us.
Thank you. This is awesome. Thanks.
Thank you. So I'm going to introduce Mariana. Mariana's been a PA for over 13 years. She's done primary care, derm, urgent care, GI. I'm not sure if I'm missing anything else, but right now she's in derm. And Mariana, how long have you been in derm?
I've been in derm now for 3 years.
Okay, awesome. And how long, or how did you get to the PA career?
Well, interestingly, my dad was a physician. I have 2 brothers who are physicians. My mom was a nurse practitioner, and I knew, and I had been a medical assistant for almost 12 years, and I knew I wanted to take the next step. But at the time I had 2 children, and I knew that going to medical school would be a big decision. So, and I had many friends that were PAs, and I loved the profession, and I thought that could definitely fulfill all my needs.
Okay, nice. What PA school did you go to?
University of Washington Medical Program.
Oh, awesome. So, it must have been like really easy for you as far as like your healthcare experience, since you were an MA before PA school.
Yeah, it definitely helped. The medics program had a big requirement for prior medical training. And so I felt pretty confident with that. And I did get accepted the first year.
Awesome. So what was your first specialty outside of school or after?
So I got hired out of my clinical rotation for primary care. I was in a family practice that did obstetrics as well. And they had known me from my kind of medical assistant experience, and they knew me from before. And so when I went to PA school, I had gone back to them and asked if they would be willing to take me on, and they said yes. And then they hired me right out of school.
Okay, awesome. And being that PAs are trained to be generalists, like primary care essentially, how easy was it to adapt and pick everything up after PA school and going into primary care?
Well, of course, when you graduate from PA school, even though they train you really well and you think that, well, you've tried to learn everything you can, you of course think you know nothing. And I think the best thing about PA school is it teaches you how to learn quickly, to know your resources, what you're going to look at, and when you don't know something, to ask a question. So I felt pretty confident that even if I didn't know something, I knew how to look it up. And if I couldn't look it up fast enough, then I would have, the resources of my colleagues to go to. But it's definitely like drinking from a fire hose the first couple of years. There were many times where I went home and just went, oh my gosh, what am I doing? I cannot do this. But you learn from it, and you are better the next day, and it works, get more and more confident.
Right, exactly. So what did you do after primary care?
So I did primary care for, it feels like a long time, but I don't know the dates, but almost, I think 5 years. And I worked in the ER at night. So after about 3 years of primary care, I decided for some reason that I wanted to do more. And so I worked in a level 2 trauma emergency room at night. And I got a lot of good experience with that. And so at that time, I obviously met a lot of the ER physicians, and one of the ER physician's husbands was a gastroenterology physician. And she gave me her vote of confidence to him, apparently, and they came to me and offered me a job in gastroenterology. And so I took all the experience I learned from primary care and started in a new specialty, and I learned really quickly. So it was nice.
Oh, awesome. That's nice. So, being that you've been able to jump from specialties to specialty, or all these different specialties, how easy was it? Like, how was it like transitioning?
Well, I think the transition, I don't want to say easy, but you get more confident learning. You get more confident knowing what you know and knowing what you don't know. And I think the transition was easier as I got further in my career, because I knew that I could just build on what I already knew. So primary care was a good place to start for me. Of course, not all PAs start in primary care. Some of them go right into a specialty, but I felt like I had a really good base for building on top of that. So it was, I don't want to say it was an easy transition, but it definitely gave me more confidence having started in primary care.
Okay, awesome. Thank you. And so we'll jump into derm now. How did you get into derm?
So if you had asked me before I went to PA school if I wanted to be a dermatology PA, I would have said absolutely not. You know, all the pictures that you see in dermatology are so, they obviously put the worst pictures in books, and they put the worst pictures in, you know, on the internet and things. And I thought, gosh, how horrible. But there's so much more to dermatology than that. And if you think about it, in a lot of specialties, especially having worked in gastroenterology, you know, you don't know that somebody has cancer until, unfortunately, it's too late a lot of times to do anything about it. And so dermatology has a lot of non-cancerous things, but it's really, it's so nice to be able to go and see a patient, educate them about care or sun or protection of things like that, and then be able to see maybe a pre-cancer on them, and then, or even a cancer, honestly, and then be able to get it off, treat it right there, and move on. It's a really cool feeling to be a lot more proactive than just reactive. And a lot of specialties, unfortunately, when you have cancer, it's just a reactive thing. It's hard to be proactive at that point. And I knew that when I got into medicine, I loved education. I loved the fact that I could get my patients involved in their own care. And dermatology totally does that. I love to be able to just teach them about how to take better care of themselves and have it make a difference.
Right. I completely agree with that. I'm definitely a big proponent on preventive care and being proactive. So definitely agree. And I do agree that derm is that type of specialty.
Another thing that dermatology does, and you know, I used to tell people in primary care, you know, people don't see diabetes happening. They don't see hypertension happening. They don't see anything else happening. And if I can point out to them, like, this is what I'm seeing, this is the damage that you're creating, let's see if we can turn this ship around, then they get it. And I just like that fact that I could do a lot more proactive things in dermatology. But I did a lot of dermatology in family practice, and I had wanted to get into dermatology after I was in gastroenterology for a little bit. I did the part of gastroenterology that I did was inpatient gastroenterology. And so unfortunately, that's very reactive, meaning, you know, somebody comes in with a GI bleed or somebody comes in with pancreatic cancer, and, you know, you're just keeping the boat afloat at that point. And I didn't like that I couldn't have a relationship with my patients. I didn't like that I couldn't follow up with them necessarily long term. And so I really like that aspect of dermatology, just to have a little bit more of a relationship and follow up with my patients. So when I got back into dermatology, or when I got into dermatology, I was able to really, you know, settle into where I was. And then I did finish my fellowship through the Society of Dermatology PAs. That took me a couple years, but I'm happy I did that.
That's great. Congratulations. Can you tell us about that? Like doing a fellowship in dermatology, the process, in case anybody wants to know or is interested?
Yeah. So it's through the Society of Dermatology PAs, which is one of the specialty groups for physician assistants. And when I looked into it, it was just this ominous proposition. There was 22 modules. You had to take tests after every module. You had to do a certain amount of CMEs and a certain amount of work. And it was a lot of book work and a lot of, learning. And, but I wanted to be the best I could be at what I did. And so I thought that I owed it to my patients and I owed it to my current and prospective colleagues that if I could get that certification, that would be really useful. And I couldn't recommend it enough. It is awesome that all the stuff that they teach you, from the very basic stuff to the stuff that you think you'll never see. But it's helped me tremendously in my career.
Okay, nice. What program did you? Well, was it like a certain institution in Washington that you did it through, or?
No, it's through the Society of Dermatology PA. So it's a specialty group.
Okay.
And so it's for PAs in the field of dermatology. And then, I mean, you can belong to the group if you want, but if it's a special certification that you have to achieve, having been in the specialty for a little bit. And it just gives, it's a certain standardized criteria for which you learn certain things. So you can then say that you have that diplomate fellowship.
Right. So you didn't have to do any extra clinical hours in a specific, or see certain amount of like skincare patients or anything like that?
Well, you have to be, be working in the field of dermatology with a board certified dermatologist. You have to attend. This year was a little weird with COVID because, you do have to attend a certain amount of CMEs, but most of the CMEs were virtual this year. So I did, virtual CMEs. You have to complete a certain amount of CMEs, and then you have to follow all their modules. They have 22 specific modules on different aspects of dermatology. So it's a bit of a self-learning, if you will, but it takes, they say it takes about 2 years to do.
Awesome. That's great. Congratulations.
Thanks.
Yeah. Okay. So my next question is, can you tell us about your like a day in the life of a dermatology PA or the group you practice with?
Mm-hmm. So it's pretty varied. I think a lot of dermatology PAs, I'll just tell you what I do. A lot of people I think it's different if you work in a private practice versus if you work in a practice, like a big corporate practice, the different criteria. So I see about 30 patients, anywhere from 25 to 30 patients a day. I see a patient every 15 minutes. I start around 8:30. And most of my day is doing skin checks. So people that have had skin cancer in the past, just a quick skin check, making sure they don't have any new skin cancers, any pre-cancers, certainly anything else. And if they do, I either treat the pre-cancers with a little liquid nitrogen or I do a biopsy. And so it's a lot of personal interaction. When I'm doing a skin exam and I know my patients, I'm talking about their dog and I'm talking about their grandkids and I'm saying, so it's a nice little interaction time. Meanwhile, I'm using my medical brain and my medical eyeballs to scan things. The other great thing about dermatology that, most medicine is like this, I think, in general, but it's about the normals. Once you know what normal looks like, you know what abnormal looks like, so it's kind of nice. You can do things quickly. So most of them are skin exams. And then I'll have an acne patient thrown in, or I'll have a psoriasis patient, or I'll see somebody with a funny rash. It's a little bit hard to get in to see dermatology patients. So we only see rashes that the primary care docs can't figure out, or the primary care providers can't figure out. And so it's not usually a super easy rash, but Sometimes it is, sometimes it isn't. But so yeah, rashes, psoriasis, acne. We see a lot of foot irregularities or nail irregularities, hair loss. Sometimes people get skin cancer diagnoses on the outside, and then they have to come in for us to look at them or take them off. A lot of cysts, which aren't my favorite, but they're that part of the skin. And then sometimes we have the really abnormal, rashes that don't fall into the normal categories, and you have to work those up with blood work or biopsies. Yeah. And then at the end of my day is always for pathology. So I'll go through my pathology people. Anybody that I've biopsied needs to get a call. I feel it's important to call those people myself. I don't let my MAs call just because I don't know. I think it's kind of a personal touch. And so I call everybody no matter what time. Sometimes I'm calling them at night if it deems a bigger conversation, and just letting them know what it was. And if I need to follow up with them, bring them back to the office and take off their skin cancer.
Nice. There's a few things that you said that I absolutely love and want to go over, because I think it's so important, especially just being a great provider. You talked about when the patients are at your bedside, how you talk to them about, their lives and their days and distract. Yeah. And also get them comfortable, make them feel, more, even though they're not at home, but it's a stress. They're under a lot of stress. They're not sure what's going on. And so I really like that you said that, because I try to do that too in the ER, especially if I'm doing like a procedure like suturing or an I&D. So I love that you said that, because it's so important, and it shows great bedside manner. And then the fact that you call your patients at the end of the day, you don't have the MA or the nurse. Anybody else do it, because talking about pathology and explaining to them the result, like, that's a very intimate and personal conversation. Mm-hmm. That you're explaining that to them, and I think it brings also reassurance and comfort to them to know that. Yeah. So I really love that that's a great provider trait.
I remember my dad did that. My dad was a physician before the time of cell phones. So he would sit in his chair and call his patients and make sure everything was okay. If they had a procedure that day, or if he was a pediatrician. So if they had a worried parent, it just made such a difference, and it doesn't take that long, really. Sometimes I'm on the phone for less than 2 minutes, but most of them are very appreciative of the phone call by me. And and I take patient education super seriously, even when I did work in a more of an acute situation where, I'm telling somebody that, about a pancreatic cancer or about a GI bleed. If you speak English to the patient, meaning medical talk is a separate language, right? When you're in school, we learn a different language, and anybody in medicine knows that you can speak a certain language to another medical provider and they understand, but most people don't know that language. And if you don't do your own translation back to non-medical terms and non-medical talk, they don't get it. And most people shake their head and they think they want you to think that they got it, but they don't understand. And they're already dealing with a serious issue. They're already dealing with either it's a complication or something they don't understand. So one of the things I just pride myself on is I really like the patient to totally get it. And they get it most times. And, I think the best part of my career as a PA has been when somebody in the hospital or not in the hospital says, I've never had somebody explain that to me before, or I've never had somebody take the time to tell me that. And they totally appreciate it. And it makes such a huge difference. I feel like I did something that no other physician has ever done before, which is just give them the time to have them understand and let them ask those questions. So anyway, that's what I like about being a PA.
Definitely. And they'll be a lot more compliant too.
Absolutely. Oh my gosh. If you take even just a little bit of time to explain why we're doing this. Like, who cares? Why are we doing this? It'll make a world of difference to them.
Definitely. I completely agree. So, being that you do a lot of skin exams, is it mainly like older patients, like as far as your patient population, are they older and you do a lot of skin cancer or have like surgery days?
Yeah, so it's a lot of older people. Unfortunately, the way that there's a lot of people, younger people who tan still, go in the tanning beds. We're seeing a lot more melanoma. We're seeing a lot more. Of course, the prevention part is I'm catching a lot of moles that haven't turned into melanoma yet, and so that's important. But, encouraging people starting at the age of 25 to come in for a routine skin exam every year, because I can scan their whole, most of their body within 7 minutes and tell them if anything's wrong. We use Dermoscopy now, which is the handheld, scopes that we use. It's kind of like a dermatologist stethoscope, meaning I have a handheld scope in my hand that I can see things in 10 power under my scope. And I can, if I think it looks abnormal with my eyeballs, I can look at with that scope and say, oh, nope, that's fine. Or, oh yeah, I don't want to, let's take that off. But even the biopsies now are super efficient, and I can biopsy a mole that I don't think looks right within a couple of minutes. So it's an efficient process.
Okay, nice. And can you tell us about the Mohs surgery?
So I don't do Mohs. PAs generally don't do Mohs, but the dermatologists do. PAs can close for Mohs surgeons, which is a whole kind of little sub-specialty thing you can learn. I don't do that, however. But the Mohs was named after Dr. Mohs, who is a dermatologist, and he developed a way to take as little amount of tissue for the best amount of surgical excision, I guess is the easiest way to say that. So it's taking just the amount of skin that gets you a clear margin around that abnormal lesion. So now people practice Mohs, which is a way to get a good removal of that skin cancer. And sometimes they leave it, depending on the physician, sometimes you can leave it open to close with secondary intention, or you can close those with sutures. But the physician in my office does do Mohs procedures, but I don't help with them.
Okay, all right. So on surgery days, do you usually help close the Mohs on surgeries? Or?
I don't. So when I do a surgery, I do full excision. So I do an elliptical excision around. Okay. And generally that's for basal cells, squamous cells, or melanoma. If it's a big melanoma, I send those to the general surgeons. Yeah, so I do that. But if it's a bigger lesion of a squamous cell or a basal cell, then I'll send those to our dermatologist, and he'll do a Mohs for that. But no, I'm again, as part of my training, I had a lot of surgical training in my PA school, and when I got out of school, I did a lot of my own. I just started doing excisions, and I got really good at them. And so now I can do an excision pretty efficiently and pretty well without having to send those out. My patients appreciate it. I think, I got used to sewing things up in the emergency room too. So I can do a lot of my own surgical stuff. It's appropriate in dermatology. If it's, something that's out of my scope, then I, of course, send those on to the physician.
It sounds like you work pretty independently.
Yeah, so that's great. I mean, I think as a PA, there are some specialties that you're definitely more autonomous than others. I I love dermatology because I can be autonomous. You can be pretty autonomous in family practice too. And even in emergency medicine, you can do things, but there's definitely more specialties that you're more autonomous. And for me, dermatology is definitely a good amount of autonomous for me. So I see, there's the good news and bad news with that. There's good news, meaning you're in charge, like all stuff stops with you, right? So if you're in charge of getting their pathology, you're in charge of following up, you're the one they call when there's a problem. So there's good stuff with being autonomous, but the bad stuff is, all the same things. You're definitely the one in charge of their happiness and their care. But I like that, I like that people call me and if they have a problem. So I do like the autonomy. So yeah, I do the whole day without seeing my physician. I have 2 medical assistants that work with me, and they're dedicated to me. So if I have questions, they take care of any problems with the patients. And then I schedule all my own surgeries. I usually have an hour at the end of the day, twice a week, to do all my surgeries. But the nice thing is in dermatology, there's a lot of quick procedures that you can do. So I'm really doing procedures most of the day, whether it's a biopsy or a cautery procedure. Yeah, so it's kind of nice. Dermatology is a good fit for me because I can do a lot of procedures and be quite autonomous.
Wow, that's amazing. That's really great. And I'm glad you're noting how much independence you have, because they see now that the PA career is just, it's full of autonomy. As long as you have that experience and you're comfortable, you can really do like any specialty and work, you can have the doctor around, but you're working by yourself. You're doing what you have.
So in gastroenterology, I was working with 7 physicians, and every week one would be on call, and then I would be the PA that did, I would do all the consultations, I would round on the patients, I would set up the procedures, but I wasn't doing a lot of the procedure. In some specialties, it's not very procedure based, and so I think that's one of the things that you have to decide in PA school or even after is how many procedures do you want to do? How autonomous do you want to be? Some people are very happy, being side by side by the physician every day. And I liked it too. I loved, working alongside the physicians all the time, but I wasn't doing enough procedures to make, I love procedures and I wanted to do more. So that's why I like, dermatology, because I'm really the one doing all that and making the decisions about what procedures people need, not just doing what somebody asked me to do.
Right. And I think when you're just getting started, it's great to, kind of be, arm in arm with the physician.
Absolutely.
Like follow the physician around and work more closely with the attending. But as you grow more comfortable, you're naturally gonna I guess kind of want to work more by yourself and have that independence. Like I know when I was starting in the ER, I was like sitting right side by side with the doctor, but now I'm just like I don't have anything else to say to them unless I need them.
Well, and you definitely have a certain level of confidence. Even in primary care, you're definitely autonomous. It's nice to have that physician kind of 2 doors down if you need them. So that's a nice amount of autonomy too. I think you just have to get confident with what you do. And I think, I certainly don't want somebody looking over my shoulder all the time and telling me, what and when to do it, because I feel like I don't need that anymore. But I definitely, again, a big part of being a physician assistant is knowing when you don't know. I tell my kids all the time, you don't know what you don't know. And if you feel if you feel you don't know something, you go ask. And there's nothing wrong with that. In fact, I have, having worked in so many specialties, I know a lot of physician colleagues that would come to me with anything because they know that I'm not gonna, tell it to them straight. If I say I don't know, they feel confident with that. And if if I say, yeah, I'll do that, then they know it's going to be done well.
Yes, yes. And I tell them that all the time. I'm glad you mentioned that, because I always say, know what you don't know. When you're getting started, or even just like 30 years in your career, if you don't know something, just voice that. It's better to, ask for help than to make a mistake. And yeah. That's so important. Know what you don't know.
Know what you don't know. There's some things you can put limits on that, but honestly, don't wing it if you don't know, because
exactly.
you can get yourself into trouble. And then if you know it, then you're good. People feel confident in you, and you feel confident in yourself. That's the other thing.
Exactly. So we're gonna move on to case studies, but before we do so, there's a few questions. So I just want to have a chance to answer some questions, and of course, if we have time at the end, we'll also answer more questions. So
Okay.
Juliana asked, "Do you ever deal with wound healing?"
All the time. Wound healing is a huge part of, and I don't know if she has any specifics about that, but wound healing is a huge part of the skin, obviously. And then in different people, if with vascular issues, if they're smokers, if they have, depending on where in the body you're dealing with, sometimes and my patients, I feel like a broken record, but in my MAs always call and roll their eyes when I tell people, but anything below the knee is like off the chart. You can't predict how anything below the knee is going to heal, because just even if somebody doesn't have any vascular changes or isn't a smoker, it just takes a really long time. So that comes into the patient education part of it. Sometimes we deal with, we really send the ones with bad wound healing, or people that aren't healing. There's wound clinics that specialize in that. And so we do send people that have, acute issues with wound healing to the wound care clinics, and they do a better job. But absolutely, we sometimes have wounds that don't heal, or at least slow healers. But I'm telling you, if you can manage a patient's expectations before a procedure or right after the procedure, you will save yourself a world of time and a world of phone calls if they know what to expect with wound healing. So that's important.
Awesome. Okay, so we have an important question I want to ask. By Emily asked it, but I think it's great for you to answer, being that you've been a PA for over 10 years, so I'm sure you've probably even experienced this. Emily wants to know, have you ever dealt with or haven't had a great relationship with your attending physician? And can you speak on the importance of the doctor-PA relationship?
Oh, it's so important. Oh my gosh. I don't even know. That's like such a loaded question. I have had a prior physician actually in gastroenterology that, and still to this day, we could be like besties, even though he was much older than I was. And I was, I don't know. We got along so well. I felt like I could say anything to him. I felt like I could get mad at him if I was frustrated. I just felt like the communication was really, really good. And vice versa. If I didn't do something well, or if he needed me to do something differently, he'd be like, "Hey, Mariana, like that could have been done differently." And so I think that communication is huge. I mean, that's an understatement. Communication is huge between the physician and the PA. It's a little bit different. It depends where you work. If you're in a big corporate situation, or if you work, and I think it depends on the specialty too. I know I'm totally muddying the waters because that's a loaded question, but it depends on the specialty. If you work closely with your physician, the communication matters more. If you work in a corporate situation where your attending physician doesn't really have to work with you closely, I don't think the relationship matters too much. You just need to go and be able to ask them a medical question and get a medically relevant answer. You don't have to be friends with that person. You know what I mean? and then people who, if you're in a private family practice, that relationship better be really darn good, because you're going to have to be going to them and being in meetings and contract negotiation. That has to be pretty close. So I think it just depends what specialty you're in, private versus corporate, what kind of business you're in. I guess that goes with the same thing. And then, yeah, how close you're working with the attending. I don't know. Do you have anything to add to that? I think it's so different in different practices.
No, yeah, I agree. I agree. It does depend on, how closely you work and what specialty you're in. And as far as like resolving an issue, it also depends on that, how comfortable you feel, or the problem you have with them, if it's serious enough to address. Sometimes it's not. Sometimes it's not even personal. Like working in healthcare, people will offend you, patients.
Oh yeah.
Your team, everybody, a lot of stuff you just got to brush off and, not take to heart. So unless it's like a personal stab or something, serious, as in like, racial prejudice, derogatory statements. And I was just like, a lot of times I brush it off. Unless it's just reoccurring, then you can have a sit down. But
yeah. I think it's becoming a lot better in the medical world that PAs and MDs work so closely together. I think a lot of even the new graduate medical doctors, they've worked with PAs, and they're in the hospital with PAs, they're in their training with PAs. MDs know what PAs can do and what they can't do and how closely they work. So, again, depending on the specialty, like orthopedics, for example, I've never worked in orthopedics, but I have a ton of colleagues in orthopedics, and a lot of the orthopedic surgeons have a PA, have like one PA that works with them. And so that relationship has to be really close and it has to be good. In some specialties, you don't really see your attending and you just have to ask them once in a while. I know that totally did not answer the question. But
I hope we were able to answer your question. So we're going to get started with the case studies. Okay, we should have time to go over 2 case studies. We're going to start with, it looks like some people already raised their hands. So good job, guys. Dorcas, it looks like, is going to come on to go through a case study. So we're just waiting on Dorcas to come on the live. Let's see if there's any short questions to answer in the meantime while we wait. Did you have a difficult time diagnosing when you first began?
Absolutely. Yeah, that's a loaded question too. I think that you get pretty confident in what you see a lot. There's always weird caveats that happen, but pretty soon you get confident in knowing what you can do, and you see things that, you see things over and over again. So your confidence level starts to build. Even in family practice, where you feel like you have to know everything, you totally don't have to know everything, but you have to know a handful of things well. And that's usually what comes in. And you get really familiar with things like UpToDate. I don't know if your viewers know what UpToDate is, but there's a couple of medical forums or medical information sites that you can access really quick, and you can just get a quick rundown of what to do if you ever get stuck. So things start coming pretty easily to you, but you don't, you're going to get stuck at least twice a day when you first start. And you can follow up with a patient later if you need to. You can always say, hey, listen, I was always really honest with my patients. I wasn't, there's a little bit of fake it till you make it. You know what I mean? People have heard that. There's a little bit of that, but my patients always felt more confident in me if I said, I'm not totally sure about this. Let me talk with my attending, or let me get back to you. And then I would always call them after the visit or always call them at the end of the day and say, hey, let's just talk about that again. So you learn quick, and then it's always that's something you planted in your brain and you don't miss it next time.
Exactly. So I'm not sure if Dorcas still wants to come on. Let's try Serenity. And any general questions you guys may have, I see you guys have some really general, like PA related questions or general PA questions. I'll answer after the live. I'll stay on a little bit to answer.
Yeah, ask questions. I love questions. Hi.
Hi. Hi. Thanks for coming on.
Thanks for having me.
Great. So I'm going to have Mariana walk you through a case study, okay? And basically ask you some questions, or I may ask some questions if I have any, okay?
Okay, cool.
All right.
Okay, and let me know if I'm totally doing this wrong, okay? Please stop me. Okay, so I'm going to tell you a case about a 30-year-old female that comes in to see me in, it can be family practice or derm, I guess, whichever you want. But 30-year-old female comes in with a rash on her body that is itchy. And she's had, or I won't tell you how long she's had it, but rash on her body that's itchy, and her PCP doesn't know what to do with her anymore. Oh, I guess I just said it was a derm, huh? Well, let's just say 30-year-old with a rash.
Okay. And then what would I be like? I would be her PCP.
Sure. I don't know how Rosalind wants to do this, but you could be her PCP. So where do you think you would start with this patient?
I would probably start with how long it's been there, if she has any specific allergies or anything that like triggers hives, if she's had hives before, if she's tried anything to alleviate like the rash.
Absolutely.
Yeah, great.
Yeah. Are we doing this right?
Yeah, I don't know. We're just going to go with it.
Great. Yeah.
Okay, cool.
Basically, that's exactly what I do. So I get a history. So I remember when I was in PA school, our medical director would say, it's all about the history, right? And that gets beat into your head in school. And there's little pearls that you'll be able to get out of the history if you ask enough questions. Mm-hmm. So absolutely, you want to say, how long have they had it? What have they tried? One thing that I always ask the patients that people really like is I say, what do you think? Which sounds like a really funny question to ask the own patient because they're sitting in front of you for knowledge. But then what that does is it opens them up to saying like, well, it was really weird after I got out of the lake. And I'm like, wait, what about that lake? Tell me about the lake, and they start giving you more information about saying, well, what do you think this is? And they can say, I have no idea. That's why I'm sitting in front of you. Or, well, it could have been this, that, or the other. And then it helps you in your history. Anyway, Rosalind, do you want her to ask me more questions or should I just say what I would do?
You can continue with what you would do.
Okay. So rash is just this huge umbrella question, and you will get it in primary care for sure. So let me take it from a primary care perspective, because once they get to the dermatologist, it's a little different. 9 times out of 10, if it's a rash that they've had for less than 2 weeks, it is either a contact irritant, so something that they got on them, or I think that's it. Like that's pretty much it. I mean, it could be, so you think about medications, you think about products. I can't tell you how many times a day I tell people to not use or to stop using the detergent that they were using, or to stop using as much soap as they're pouring on themselves in the shower. Older people have trouble with showers in general. So my number one question that I ask people with a rash that's been going on, an itchy rash, is, do you take a shower every day? And I know that sounds really weird, but most people who take showers every day ruin their skin. They just ruin their skin because it's like they take all the oils away. Anyway, so that's a good question. You ask them if it's itchy or not, because itchy usually means inflammation, and itchy usually means like an inflammatory irritation. So if it's, is it itchy? How long has it been there? What products do you use? What makes it worse? What makes it better? All your normal history questions. And generally in a primary care setting, there is always a trigger. So you have to try to figure out that trigger. Topical steroids will take it away. But if you don't take away the trigger, you're going to see them back in 2 weeks and it's still going to be there. So I always say, I know, this is what I always say too. I know I can tell you how to fix it, but I can't tell you what caused it. And so then you're putting the ball in their court. What caused it? Is it your shampoo? Is it your new soap? Is it your new perfume? Is it your new detergent? Are you taking showers twice a day and you're totally ruining your skin? So you're gonna run into rashes all the time. But the biggest question is, how long has it been there? If it's been there less than 2 weeks, this isn't an autoimmune thing, right? If it's been there less than 2 weeks, it's not, generally it's not a rash that was caused by a drug. It could be, I mean, you got to ask them about drugs, but the itchy rash is generally something that they're putting on their skin.
I used to work at a urgent care clinic. So a lot of the PAs would always be like, is this like poison ivy? Is this scabies? Is this like just like contact derm? So I've seen like a little bit of it, but I can never tell the difference between them.
Well, you will, the nice thing about rashes is most of them have a bit of a characteristic to them. Poison oak is going to be, first of all, you're going to ask the history, were you rolling around in the bushes? Were you just hiking? Were you just camping? If they haven't been camping, if they haven't been pulling weeds, if they haven't been outside, it's probably not going to be poison oak.
Right.
You know what I mean? So, but those rashes, you'll start learning what rashes look appropriate and which don't. Scabies generally looks the same on everybody. Poison oak generally looks the same on everybody. Shingles generally looks the same on everybody. So the nice thing is you see a couple of cases of that and you will be able to call a scabies or a shingles case every single time. You'll be like the shingles expert. And I'm sure in urgent care, you've seen shingles before. You wouldn't miss another shingles.
Oh, yeah. Yeah, I've seen that. I accidentally touched it, so that was good.
Yeah, well. Yeah. What year are you, what do you do right now?
I'm taking my second gap year. So I applied this cycle, but I didn't get in, so I'm reapplying. But right now I work as a medical assistant at a dermatology clinic, and they specialize in Mohs surgery. So I assist with Mohs.
All right. What do you want to go into? Is that too soon to ask?
Yeah, I don't know. I thought I wanted to do pediatrics, but just because I've been working a lot with geriatric patients right now, just because they're the ones that are very that's just kind of the patient demographic that I work with right now. I kind of really like it. So maybe geriatric or some sort of primary care.
Well, you get a lot of geriatrics in dermatology. Well, that's really cool. Any more questions about rashes? I guess rashes are such a can of worms, but you see a rash and a lot of times you look at it and you just, like I said at the beginning, you know what normal is and you know what abnormal is. So it's a rash, But if, is it on a dermatome? Is it blistery? There's only some certain types of blistery rashes. Is it itchy? There's not, a lot of the drug rashes aren't itchy. Psoriasis, not itchy. Psoriasis and atopic dermatitis, those look very similar, but one's itchy, one's not. So you just will learn to build your own toolbox over time. And that's the really nice thing about medicine is your toolbox keeps getting bigger and bigger and bigger of knowledge. Yeah. So just like you said, the case, the presentation is, when you see the patient, you're going to ask all those exact questions that you were talking about. You want to get how long the rash has been there. You want to get where the rash is. A little pearl of dermatology is, if it is a contact rash, it's usually not in the armpits, right? So I always ask, can I see your armpits? And I always joke, like, you'll never hear that question again. But drug rashes, absolutely. If it's something they're putting in their mouth, it's a systemic rash, and you're going to have that rash all over. You're going to have it in the gluteal folds. You're going to have it in the armpits. It's suddenly not a contact, it's not from the contact. You can kind of rule that out. So anyway, little pearls. Yeah. But you're exactly right. You want to just get most of the information from the history.
Awesome.
Cool.
Great job, Karina. Do you have any other questions for Mariana?
No, I don't have any questions.
Awesome.
Thank you for having me.
Feel free, and I guess this goes for anybody. Feel free to contact me if you have any specific questions. I am totally fine with answering specific stuff or helping out with whatever I can.
Thank you so much. How can we reach you?
How can they reach me?
Yes.
So I think the easiest way is, so you gave my Instagram account. They can message me with any questions. And then did I give you my email address?
I have your email, yes.
Okay, I'm okay if anybody wants to email me at Mariana Cooper, MARIANA Cooper, COOPER @yahoo.com.
Great, and I'll also put your Instagram in there too. Okay. All right, so it's 8:00, so we don't have time for another case study, but that one was awesome.
I'm so sorry. I didn't know what to talk about.
No, it was great. But before we go, I actually wanted you to really quick touch on or give your opinion on steroids. Because I know it's prescribed a lot in derm, as far as like topical steroids and systemic. So I want to know your take on steroids.
Okay, my nutshell on steroids. Steroids are awesome. Okay, steroids are awesome. However, they are meant to put out fires, right? So I tell people all the time, there are things that are fire prevention and there are things that are fire extinguishers. And I describe the steroids as a fire extinguisher, meaning you shouldn't have to use the fire extinguisher all the time. And people get that analogy. One of the things that's so awesome in medicine is I use analogies all the time. We talk about talking to the patient and having them understand. You got to talk about things they understand. Anyway, so steroids are awesome. When you have a flare, a rash, something horribly itchy, something horribly inflamed, a steroid will put the fire out. I think a lot of people get used to using the steroids because they think it's just an all-over cream they can put on all the time, and it's absolutely not. Steroids cause atrophy of the skin. They cause permanent scarring sometimes. They cause striations if used too long. And that's if they're really abused. I have seen those a handful of times on people that come to me and they've been using their topical steroids for a year, every day for a year. So sometimes it's bad, but if there are definitely cases that we use steroids for 2 months, 3 months, 4 months sometimes. The pharmacist will always scare your patient out of using a topical steroid for as long as I have told them. And so I do use topical steroids for longer than 2 weeks. I tell them the pharmacist, but again, patient education. I tell them the pharmacist will tell you not to use this. smile and nod, and then do what I said. And that gets them out of like, what? Mariana didn't tell me. Da, da, da. So then it pits the pharmacist against me. I always say, look, the pharmacist is going to tell you something different. That's okay. They're trained to do that, but then do what I said. So steroids are awesome. I tell people how to use them. I tell people how not to use them, and they love them. So steroids are okay. We don't use a ton of oral steroids. By the time they get to us, dermatology, we don't use a lot of oral steroids. We do in some cases, but for things like some of the more chronic rashes, it's just not as widely used. We have other things that we should do at that point.
Right. Awesome. Thank you so much for that. I completely agree. I love that extinguisher analogy. Awesome. Thank you so much.
All right. Thanks, guys. Ask me any questions. No problem.
Thank you. Her email again is marianacooper@yahoo.com, and her Instagram is @soderm_PA. So we've ran out of time, but feel free to just email her or DM her your questions. She's great. She's so nice and knowledgeable. Thank you so much, Mariana.
Okay. Good luck, everybody. See you later.
Good night, everyone.
Okay. Good night. Bye-bye.
Bye.